Hello everyone, we'll be starting shortly. Right, hello everyone. Thank you for those who are able to make it live. If not, this will be posted. You'll be able to watch it a couple days later. So we're going to start first with some questions, some sample questions. This stream will be focused more on GI questions. And it'll be just a couple of scenarios with different types of answers. And also we'll go behind, I'll try to break down the reasoning behind these questions and what the examiners want from them. So the first scenario that we have is someone called Mrs. Jones, who is a woman in her 40s. She has been admitted to the accident emergency department with severe pain in the epigastric region, which has radiated through to her back. She complains of feeling nauseous and she has vomited twice. On examination, she is pale, she is jaundiced, she is tachycardic with 110 beats per minute, she has a low blood pressure of 90/60, and on abdominal examination, we have ecchymosis of the flanks, tenderness in the epigastric area, and bowel sounds are present. So what we have here is quite a lot of different clues here. So the first thing we know is that she has sudden onset severe pain. It's in the epigastric region, and it radiates to her back. So just from this, it should give us a clue of what's happening. So we might suspect that this could be some sort of pancreatitis, because of the pain that's in the epigastrium going through the back. She has vomited. However, it's slightly complicated because she's also jaundiced. And that's not really typical of pancreatitis. We have some ecchymosis of the flanks, which means just bruising, and tenderness in the epigastric area. And that still confirms more of a pancreatitis picture. And we sort of exclude any obstruction or any perforation because the bowel sounds are present. So as the question suggests, you will always get an answer to the question. You'll have a scenario, and unless the question asks, "Oh, what's the diagnosis?" It will always tell you it's acute pancreatitis. And this is because the examiners are not trying to trick you. Because if you don't get the correct diagnosis, then the subsequent questions you will not be able to answer. That's not they're not trying to trick you like this. If it's a question that if the answer for the previous question is needed in the next question, they'll give you the correct answer. Okay. So this is second year exams. There'll be a lot of anatomy, and they might easily ask you to label a diagram like this. So this is a typical diagram of the hepatobiliary system. We have different parts here. So imagine this is the liver, that's the gallbladder, that would be the spleen, and that would be the pancreas there. And they're asking us to label this. So what do we have here? So these are some blood vessels, as we can see. And if I can convince you, these would be arteries. So this is asking about arterial supply of the hepatopancreatic system. So this is the spleen here, which is a very vascular organ. This would be the splenic artery, which is very tortuous. And so that would be E, is splenic artery. F, of course, would be the spleen. What's sort of cut out here is the stomach. So this is where you would expect the stomach to be. That's sort of cut out of this picture. A is one of the arteries that sort of emerges from the celiac trunk and the gastroduodenal arteries. So this one here would be one of the gastroduodenal. So it supplies the stomach and the duodenum. B itself is the duodenum. So as I said, this is the stomach here. Imagine that's just been cut off to reveal the pancreas. Once again, this is the head of the pancreas, neck, body, and tail. Then we have a look at the D. So what artery is here, D? So if we imagine that the aorta is behind this, right? The aorta is just behind this. This would be the superior mesenteric artery. which is one of the key arteries that emerges at L1, L2. And it supplies the gut. We also have C, the head of pancreas, and F is the spleen. Now, this is a sort of typical picture that might come up, and it's good to sort of have an intimate knowledge of the anatomy for certain parts. Of course, it's 1, 2, 3, 4, 5, 6, and something with 6 points might be worth 3 marks. So that means you would get a mark if you get 2 correct, and you would get half marks every other way. So this might be only 3 marks. So you're not going to lose that many points, but it's good to know the anatomy of certain key aspects, like the hepatobiliary tree. Okay, so that's just the answers there. And the key points from this is that the pancreas is a retroperitoneal hooked shape organ. The main blood supply is via the splenic artery, which is the celiac trunk branch, and the splenic artery, which supplies the neck, body, and tail, whereas the pancreatoduodenal arteries just supply the head. And if we go back, so this here would be the gastroduodenal, and from that emerges the pancreatoduodenal arteries. And they supply the head of the pancreas as well as the duodenum. So the arteries are just describe what they're supplying. Gastroduodenal artery supplies the stomach, so the gastrum, and the duodenum. Okay, so now let's move on to some physiology questions. So what 4 enzymes are produced by the pancreas? So the pancreas produces lots of different enzymes, but they're only asking for 4. And whenever they ask any question about enzymes, this might be 4 marks. You can't just write one thing, right? If it was just what 4 enzymes are produced, it might just be 2 marks. So you get half a mark per correct answer. But if this was 4 marks, then they would also expect you to answer what the target is. So you always have to calculate the amount of marks and then assume what they would want from you. So if this was 4 marks, you would say the enzyme and the target. If this is 2 marks, you just list the 4 enzymes, and they will say list 4 enzymes. So we have amylase, so that's pancreatic amylase, which targets starch. We have trypsin and chymotrypsin, and these two are they target proteins. And the reason why this is important is because they are zymogens. So they need to become activated first. Once they become activated by cleaving, they can be in an active form to digest the proteins. Next, we have elastase, which is also a type of protein. We also have stuff like ribonuclease, which breaks down amino acids within the DNA. And then we also have lipases, which are for lipids. And as I said, these are zymogens. And zymogens are just precursor enzymes that need to be cleaved. Okay, let's move on to the next question. So we order an ultrasound scan, and it shows a bile duct dilatation. What is the most likely cause? So in these MEQs, you will usually get a scenario or a story, and it's a very clinical scenario or story. And this is a sort of change from what you might be used to maybe in first year, and then especially in the 3rd year and 4th year, 5th year exams, it'll be more clinical scenarios. And as you can see, the story is evolving. So the woman had abdominal pain. We're doing the scans now, and the scans should have a finding. So what is the finding? It's a bile duct dilatation. Now this is a key sort of symptom or a key investigation result that you need to know about. And the causes of bile duct dilatation is gallstones. And these gallstones come from the gallbladder, and they get impacted within the biliary tree. So this is the cystic duct, common bile duct, or the rest of the biliary tree. And I'll have on the next slide a picture of that. So once again, it's another anatomy labeling exercise. As you can see, there's quite a lot of them. So it's 1, 2, 3, 4, 5, 6, 7, 8. There's 8 pieces. This would usually be worth around 4 marks. And we need to just sort of visualize what's happening. So we know that this is the gallbladder. That's the gallbladder. If you can imagine, the liver is sort of sitting here on top. And here you would have the pancreas feeding in. Okay? So that's the liver. So this would be the hepatic ducts. So this is the left hepatic duct. Because it's on the left-hand side, that would be the right hepatic duct. And they come together into a common hepatic duct. And this common hepatic duct travels down. And where it meets with the cystic duct, which just means for gallbladder, that it becomes the common bile duct, which is what A is. A is the common bile duct. Now, the gallbladder is a bladder, and another word for bladder is cystic. So cystic duct would mean like the content of a bladder, because it's a gallbladder. So this is the cystic duct, and that connects to the gallbladder here. We also have a specific area, which is H, within the gallbladder, that's called the Hartmann's pouch. And the Hartmann's pouch, which we'll go into a bit later, is a site of pathology. So it's not part of the normal anatomy of a gallbladder, but in a pathological gallbladder, it's a special pouch where the stones might be impacted. So we travel down the biliary tree, and we see the pancreatic duct coming here in B, and it joins together. And where it joins together, it becomes the hepatopancreatic ampulla. That's the anatomical name. The eponymous name, which is when it's named after someone, is the hepatopancreatic, is the ampulla of Vater. So ampulla of Vater or the hepatopancreatic ampulla is the same thing. It's just a different name. One is the eponymous name, which is if it's named after someone, like Cushing syndrome. And the other is the correct anatomical name. Just like the Achilles tendon and the gastrocnemius tendon. Then with D, this is a sort of questionable thing here, because what could this be? So D is the major duodenal papilla. So if you think about it, the ducts come together and then they have to exit somewhere. Where the ampulla exits, which is roughly a third of the way of the duodenum, that's where it's called the major duodenal papilla. Now this has an embryological importance, because from this point onwards, that's called the midgut. Before that is the foregut, and from this point onwards, it's the midgut. So it has an embryological implication, and when you have different abnormalities and different blood supplies based on this. So that's its significance. So this is just with the answers. So just to go over it again, we have so G would be the hepatic duct. Two hepatic ducts form a common hepatic duct. When the cystic duct from the gallbladder joins with it, it has a common bile duct. And then we have at B, the pancreatic duct, together forming the ampulla of Vater. Now let's talk a little bit more about the Hartmann's pouch. So the gallbladder has four main positions. It has the fundus, which is the sort of tip of it. It's the body. We have the neck. And then we have the theoretical space, the Hartmann's pouch. Within the gallbladder, we have something called crypts of Luschka. And these crypts help concentrate the gallbladder, concentrate the contents of the gallbladder, which is bile. And it does this by resorbing, so that once all the bile salts are present, and when it needs to be excreted to digest fatty foods for emulsification, it is ready and at the right concentrations. And it's similar to the stomach in that sense, because it has folds, spiral folds, and all these crypts. It's very similar to that. It's just much smaller, and its job is to absorb water so that the bile becomes more concentrated. Now, what can happen is that we can get stones lodged in here. So if a stone lodges in here, it creates a little pouch, which is known as the Hartmann's pouch. And on the next slide here, you'll have a simplified drawing. So we have the common hepatic duct, common bile duct, and pancreatic duct, and together they make the ampulla of Vater. So as you can see, it's not very complicated, but there are some key structures, and with the gallstones, they can get stuck anywhere. So a gallstone can get stuck here, can get stuck within a cystic duct, common bile duct, or it can be stuck here. And each of these have different pathologies depending where it's stuck. So if we have a gallbladder stuck here, you won't really get jaundice because it's not interfering with the liver. However, if you get a blockage here, well, that can cause jaundice. And if you get a blockage here, that will cause a pancreatitis because the pancreatic juices can't leave. So depending where the stone is lodged and the stone might progress, the condition can worsen. So gallstone pathology is quite complex. However, if you understand the anatomy, it makes sense. And sometimes it just helps, even once you're in your clinical years, to just draw it out so you can see where everything is. Okay, let's move on. So, we've made some progress, and we go talk to the patient again. So Mrs. Jones tells us now that before this episode, she had intermittent pain that comes and goes with meals, especially if it's fatty or fried. That's another indication. Fatty or fried food. As we know before, the gallbladder, its role is to help digest these fatty tissues and this fatty food. She then points to her right-hand side under her ribs where she says that there is pain. She also says she gets occasional shoulder pain. What is the cause of this? And why is she getting the shoulder pain? So this might seem like an unrelated problem, right? Shoulder pain, maybe she injured herself, something like that. However, it's related to the gallbladder quite significantly, and we'll go to the anatomy after that. So what is the likely cause? So this is called cholestatic. So it's the inflammation of the gallbladder and the duct. And in the previous picture, as I showed, this is where when the stone is not in the common bile duct. It's when it's within the cystic duct or within the gallbladder. So it's not having an effect on the rest of the biliary tree. So you'll get inflammation, you'll get pain, and you sometimes may get jaundice, but it's more likely to be just cholestatic and inflammation. Sometimes the inflammation can get towards the liver, and you can get an inflamed liver. This is because the gallbladder is in such close proximity to the liver and can affect that. And especially if you get a very inflamed and mucky gallbladder, it can sort of fistulate into the liver and can cause more inflammation. And that can result in jaundice. But stereotypically, you wouldn't really get jaundice from it. So cholestatic. And then the question is, why is she getting pain? Well, this is something called referred pain. And we get referred pain because it's linked to other nerves next to it. So this is because of the phrenic nerve. So what is the phrenic nerve? So if we look at the anatomy here, we see that the phrenic nerve comes here to supply the diaphragm. And a good way to memorize this is C345. It keeps the diaphragm alive. And it's in particular the C4 nerve, which also innervates not only the diaphragm, but also the shoulder. And if you get inflammation within the liver and the gallbladder, that can irritate the diaphragm, which irritates the C4 fibers, which is responsible for the sensation of the shoulder. Now, what this does is called something a regimental patch, which is in the army, you would have the regimental patch right on your shoulder. And that's where you get that sensation. So it's the C4 distribution. And it's because it's a shared pathway. So this is called referred pain. And just to recap, that's because of the phrenic nerve being close to the diaphragm and having a shared pathway. Another example of referred pain would be when women have ectopic pregnancy, and they can also get shoulder tip pain because it's within the abdomen and it can inflame the diaphragm. And once again, it's the same type of pain. Okay. Let's just recap. So next question is, how is the gallbladder contraction controlled? So how do we control the gallbladder contraction? Well, we know that it responds to fatty food. But how does it know to respond for fatty food? Well, there's a special communicator molecule called cholecystokinin, and is released by the cells in the duodenum when it's stimulated by fatty or acidic chyme. And chyme is the stuff that comes from your stomach after it's digested. And what happens essentially is there's a pictogram here. It's through the vagus nerve and through the gallbladder. The cells release the CCK, the cholecystokinin. This gets detected in the blood vessels and goes all the way through the vagus nerve and gives a reflex to the gallbladder to start secreting. And this does, the secretion happens through the contraction of the smooth muscle cell. And it detects the CCK and it tells it, okay, you can release. And this is why people with cholestatic or biliary colic might get pain when they eat fatty foods. And one of the solutions for this, if they don't want an operation, is to decrease the fatty intake of food. Of course, people who have gallstones generally have an unhealthy lifestyle, a lot of fatty food, and also not eating as healthily. And this results in further exacerbations of predisposition to gallbladder disease because the gallstones themselves are made from cholesterol and fat. So it's a whole pathological syndrome there. All right. So you decide to send some bloods, including liver function tests, LFTs, and this comes back. So we have alkaline phosphatase, so that's your ALP. We have our ALT, which is your alanine transaminases, which is specific to the liver. We have bilirubin, and then we have conjugated bilirubin. So what do these results indicate? So our ALP is quite significantly raised. And ALP is found in bones, and it's found in the biliary tree. And it's found in the common bile duct, it's in the ducts. And the cells release this when there's damage. So it's showing that there might be some problem with the biliary tree. We see some hepatic inflammation, however, it's not that high. But our main concern is the bilirubin. So she's jaundiced, okay? We're suspecting a gallstone because she's had episodes of this cholestatic. And then we look at the bilirubin differential and we see it's mainly conjugated. So this means that the liver works, right? Because the conjugation process is done by the liver. So it's not going to be an intrahepatic or prehepatic problem. It's going to be a post-hepatic problem. And what we call this obstructive jaundice. Now, we have 3 different types of jaundice. We have a prehepatic jaundice, which is where the red blood cells get broken down through hemolysis into hemoglobin and bilirubin later on. So that's one way, but that would be unconjugated bilirubin. But that's not the case here. Then we have a hepatic issue, which is a hepatic jaundice, where we can't convert the bilirubin. And this could be viral hepatitis, this could be drugs, this can be cirrhosis, this can be a liver tumor. And all of these prevent the breakdown of bilirubin, or the conversion of bilirubin to conjugate bilirubin. And then finally, we have post-hepatic. And there's a number of causes for this. We can have obstruction of a bile duct with a stone. We can have cancers, either of the pancreas. We can have cancers of the ampulla, or we can have cancers of the common bile duct, called a cholangiocarcinoma. Basically, this just causes obstruction, and the bile salts sort of get reabsorbed, and they don't get processed. And this leaks into the circulation, and we have this conjugated bilirubin, which is in excess. Okay, let's move on to the next question. So what's the reasoning behind this? We sort of explained this before. So the conjugation occurs in the liver. Most of the bilirubin becomes conjugated, so the liver is intact. ALP is found in the bile duct lining, which suggests obstruction. I suggest the same picture. So here are some questions about bilirubin. So the first question is, how is bilirubin produced? We sort of covered this already. Bilirubin is formed as a byproduct of heme destruction, and heme comes from red blood cells. So red blood cells are broken down in the spleen. Red blood cells have an average lifespan of around 120 days, and this is regulated by the spleen. And the reason we break down the red blood cells is so that we can repackage and reuse the heme once the cells become less viable and not as efficient with their gas exchange. Now, bilirubin needs to travel in the venous blood. And this is because bilirubin is insoluble. So how does it travel? So it binds to a protein called albumin. And when the spleen produces this bilirubin, it's not soluble. You can't do anything with it. And the only way to get rid of this bilirubin is if it binds to albumin and it can travel through the circulation. Now, the second question, through which veins does bilirubin travel from spleen to liver? Now, if we go back to the anatomy, we know that the spleen is connected to the rest of the system, to the portal system. And it happens through the splenic vein and the portal vein. So if we imagine the spleen is here, it travels through the splenic vein into the portal, and that goes into the liver. That's your portal circulation. It goes from the spleen to the splenic arch vein, and then up through the hepatic portal vein. So what reduces bilirubin to urobilinogen in the intestine? So bilirubin needs to get processed. And within the intestines, it's actually the bacteria which break down this bilirubin into urobilinogen. And this happens after it's been conjugated by the liver and processed, because bilirubin is sort of like a waste. It's not good to have around. It causes jaundice, it causes irritation, it causes itching. So the bacteria within the gut convert bilirubin into urobilinogen. And this urobilinogen causes the changes in color of stool. And then how else is urobilinogen lost? Well, it's lost through urine and through feces. And this gets important in one of the other scenarios where if we have obstructive jaundice, we might get pale stools and dark urine. And that's because of the bilirubin in the urine and the lack of pigment because of the lack of bilirubin in the intestine. And this is what the next question is here. So the pale stool is because of lack of bile pigments to give stool their color. So stool is usually greenish in color, and it's the bile pigments that give it this brownish color. Same thing with the urine. This is because you get excess bilirubin. Bilirubin is a very dark molecule. Okay. Moving onwards. So the story continues. So Mrs. Jones undergoes an endoscopic retrograde cholangiopancreatography, which is known as an ERCP. What is one serious and one catastrophic side effect? So they're asking the side effects of the ERCP. Now this might usually be 1 mark, so it'll be half a mark each, or it could be 2 marks. And this is quite a niche question. However, it is very important clinically to see the difference between these effects. So a serious side effect is pancreatitis. So ironically, we try to fix this problem, and we might give the patient pancreatitis. And this pancreatitis can be very severe. And a catastrophic side effect is mortality. So there's a 1% chance of death with this procedure. And this is because it's a very demanding procedure for the body. And for those who do not know what an ERCP is, well, we pass an endoscope down the throat, down the gullet, into the stomach, and through the duodenum. And then at the ampulla, there's a little wire. And this wire goes up and it tries to retrieve the stones. We can also do something called stenting. So let's say it's so blocked that you can't get anything in and out and it's causing obstruction. So what you can do is you can come in and you can put a stent, just like in a blood vessel. And this stent will increase this space here. And it will keep it patent so that bile can drain. And once the bile drains, it enables, it sort of prevents the obstruction from happening again. But this is usually done in cancer patients, the stents. However, to remove the stones, this is a very common way to do this. And another benefit of the ERCP is that it's both diagnostic and therapeutic. So you go in and you can have a look inside the biliary tree, and at the same time, you can also repair things. But the side effect is pancreatitis. So the CT scan that you requested has come back, and this is the diagram here. So we actually got this question in my second year exams. It was a similar question like this, which was a cross section of the abdomen of a CT scan. We also got it in our OSCEs in fourth year, so it's good to know. This might seem like superfluous knowledge, but it's quite useful to know about these things. So this is a transverse section, so that's the first thing. It's a CT. How do I know that it's a CT? It's because I can see it looks like an X-ray type thing, and we can see the contrast because of all the different colors. Now this can be quite tricky to understand, but we need to orientate ourselves. So this is left, always left and right. So this is left. So this is left here. This is right, and you're looking as if this is the feet here. That's the feet there, right? So you're looking at the edge of the bed type of thing. And what happens afterwards? So this are the kidneys. That's the spine. These are blood vessels. Now this one here is G, is the aorta, and aorta is always more towards the left-hand side. And this one D here is the inferior vena cava. So inferior vena cava is always more to the right-hand side. And that's just the way embryology defines it. That's how, that's just how it's formed. And I'll show you another picture to sort of further establish this point. So that's aorta, which is always much more circular and sort of thicker. And then we have the inferior vena cava. So we orientated there. Then we have the muscles. So F is something called the psoas muscle, and it lies very close to the spine. And this is a hip flexor, and sometimes you can get something called an abscess within the psoas muscle, which is quite kind of an emergency. But this is not relevant to this scenario, but it's a psoas muscle. And then what do we have here? So this here is intestines. It's nice and bubbly. We fill it with gas. We also have the edge of the liver here. So that's the liver there. And then we have all these structures. So E, I know it's quite difficult to say, but that's the supramesenteric artery. This little aspect here is the pancreas. And if I can convince you of this little line separation, if you look at it at the full screen, that little line there, that's the division between the, you see it just so faintly, that's the division between the duodenum and the pancreas. So it's where the pancreas and the duodenum interact with each other and intersect. So if you remember this from like a sagittal perspective, that's the duodenum, like that, and the pancreas is here. So that's what we're looking at, but we're looking at it from the bottom. So we're looking at it as if from this view, if that makes sense. And so that's the duodenum there, and that's the pancreas. And then H at the back, so you can see that just ever so slightly, and that will be part of diaphragm. That's the diaphragm tendon. Yeah, so once again, just to recap, A, head of pancreas, B is the duodenum, C is the liver edge, and D is the inferior vena cava because it's more on the right-hand side. Now, if we go on to this picture here, this is what I was alluding to. That's the duodenum there, that's the pancreas, and this is the duodenum at this level. And the rest is the pancreas. So it's like a cut. It's a transverse cut. And if we go on to the next picture, we'll see the inferior vena cava. So the inferior vena cava is always more towards the right-hand side, and the aorta is always more towards the left-hand side / midline. And this is just an anatomical fact that you need to know. It's also always a little bit close to the spinal processes, and the inferior vena cava is always more towards the right-hand side. Okay, so that's the first scenario. So that was just the whole idea of abdominal pain and the different differentials for that. Next, what we're moving on to is going to be painless jaundice. So it's in a similar vein, but it's slightly different scenario. So at first, we just have a look at the differences in the scenarios. So we see it's a man. He's 50, so a little bit older, and he presents with jaundice. It's jaundice again. But for the risk factors for gallstones, it's the 4 Fs. So it's female, fair, fertile, so could be pregnant, 40, which is middle-aged, and fat, so overweight. So that's the sort of risk factors for there. But here we have a man who's 50 years old and has jaundice. Another key sign is he has lost weight. So whenever a patient loses weight in a short amount of time and is feeling tired, that should always sort of light a bulb in your head of thinking, okay, is this a cancer? Especially if he was previously well and healthy. So losing weight, middle-aged man, tired, and jaundiced. So you should always be thinking, okay, could this be a cancer? And on examination, there is no tenderness. Okay? But you feel the gallbladder. Okay? You feel the gallbladder, he's lost weight, and he's not tender. So the first question they're going to ask, what's the landmark for the fundus of the gallbladder? Now, this is quite a straightforward answer. And it would be the right costal margin within the midclavicular line where the rectus abdominis muscle meets the ribcage. What does that mean? So this is a visual representation of this. And essentially, if you can imagine the abdominals here, the abdominal muscles, give this mannequin a nice six-pack. It's where the rectus muscles insert into the ribcage. Now, many surgical textbooks will define this as the tip of the 9th costal cartilage. However, this is not very useful for us because unless they're opened up or it's in an anatomy prosection, the costal cartilages cannot be distinguished from one another clinically. These are the costal cartilages. Because clinically they form one, they join up together. So that's one thing. Another thing is that the position of the gallbladder can vary based on the individual's anatomy. So sometimes some people, and you'll see this in your surgical blocks, might have a gallbladder that pops up this way and it's more closer to the liver. Others might have it this way, which is much less common. But the traditional way that it points down. Different people have different sizes of gallbladders, so it depends. But generally, it's within the right costal margin, mid-clavicular line. So you draw a line from the mid of the clavicle, and you find where you meet with the rib cage. Anyway, so that's the right costal margin, mid-clavicular line, where it meets the rib cage. Next, what is Courvoisier's law? So Courvoisier was a Swiss surgeon. And what he discovered is that if you have jaundice and it's not painless, and it's painless, you don't feel anything, but there's a palpable gallbladder, it is unlikely to be due to gallstones, and you should suspect other pathology, most commonly tumors. So how does this make sense? So the reason this makes sense is that when we have gallstones, they cause inflammation. So we have a gallbladder, and we have little stones in there. And this causes inflammation, right? This causes inflammation within the gallbladder. And what happens is that the gallbladder starts to fibrose. It starts, having a fibrotic process. And as a result, that makes the gallbladder smaller. So it's smaller. It shrinks because of the stones. And this is why the stones can cause more troubles, because they're shrunk. And due to this shrinking, it's like pulling the gallbladder down. The bladder itself will become less palpable. So you're less likely to feel an inflamed gallbladder because it shrinks down. Now, compare that to a tumor blocking something either within the gallbladder itself or further down. It will cause a blockage and essentially expand the gallbladder. And as it expands, it's because of the poor outflow. And this means that it's not likely due to gallstones, it's due to another pathology. And the reasoning behind that is that in gallstones, it shrinks due to fibrosis. And here is a sort of visual representation of Courvoisier's law. It's a quite extreme representation. But you see a mass here, we see a mass here. And if they're noticeable and palpable, then it's probably a diagnosis of cancer. And you can see that they're quite jaundiced as well, this patient. So this is known as Courvoisier's law. Once again, if it's palpable, if it's jaundiced and it's painless, it's unlikely to be a gallstone, it's likely to be a cancer. Moving on. So painless jaundice, plot thickens here. So Mr. Andres is complaining of an itchiness. He says it keeps him up at night. You look at his skin and you notice excoriations and scratch marks all over his body. What is this called? So this is called pruritus. What is the likely cause of pruritus in this patient? Well, it's something called bile salt deposition. And we have a suspicion of obstructive jaundice, just like this previous case. However, the level of this obstruction is so bad that these bile salts get deposited in the skin. And this causes an unbearable itch, and patients will not be able to keep their hands off from scratching themselves. It's a very terrible itch. So how do we treat this? And what's the mechanism behind it? So we can give them something called cholestyramine. And cholestyramine works in a very, very clever way because it binds to the bile acids within the small intestine and prevents reabsorption. So it not only treats the itchiness, but also may prevent further issues associated with bile salt deposition. And by preventing reabsorption, the bile salts are just excreted. They don't enter hepatic recirculation through the portal veins, therefore there's no deposits. And you just excrete it out. Moving on. So you suspect obstructive jaundice. You want to confirm your suspicions. So you give liver function tests. Now, liver function tests are actually a misnomer. They do not measure liver function. Well, at least not directly. They look at the enzymes present within the liver. This is why we have elevated ALT and AST indicating liver damage, because these enzymes are increased and are lost in the blood when there is an injury. These hepatocytes die off and they release their contents, and their contents contain this ALT and AST. Thus, they only show a sign of liver injury. But to assess the synthetic function, or the function of the liver, you want to assess the synthetic function. So how do you do this? Well, we look at its ability to produce proteins. And there's two tests which are quite easy to do. So these are blood tests. We look at prothrombin, or the prothrombin time, I should say. And prothrombin time is a measure of all the clotting factors within the extrinsic pathway of the clotting cascade. And it will be prolonged because the time to sort of make up these clotting factors is not present because you don't have enough synthetic function from the liver to produce these clotting factors. And a prolonged PT time is associated with many things. It can be impaired liver function, it can be poor vitamin K absorption, it can be drugs like warfarin which inhibit vitamin K, or it could be conditions like DIC where they use up all the clotting factors. Now, prothrombin time is only extrinsic. However, all clotting factors are made within the liver except for factor 8. And that's why PT time is a good measure for liver function. Of the LFTs, only albumin, or the level of albumin, is a marker of synthetic function. And albumin is only made by the liver. So it's a very specific factor to the liver. And we produce roughly 10 grams of protein each day, assuming like a 70 or 80 kilo person. So if the albumin level is decreased, that's a good indication that our liver is not producing as well as it should. Anyway, moving onward. So we did a blood test. We examined the patient. We did a blood test. What's the next thing we do? We ordered an imaging. What we ordered is an MRCP, which is a magnetic resonance cholangiopantiography. So it's similar to the ERCP. However, it's just an image. We inject the dye into the biliary tree and take a picture with a sort of MRI scan. And this is different from an ERCP. It's because in an ERCP, we can go in and do an intervention, whereas this is only diagnostic. And ERCP is diagnostic and therapeutic. So what we're looking at here is a coronal section. So imagine, this is what the picture we see in an anatomy textbook. So that's the pancreas there. That's the biliary tree, and that's the liver there. So pancreas is here, and that's the liver here. That would be the duodenum. So the question is, what is shown on this biliary tree? And this is something called double duct sign. So one duct is here, and I'll just show the previous image. So double duct sign applies to the pancreatic duct and the common bile duct. And it is the dilatation in both of these that is indicative of a pancreatic cancer or a ampulla of Vater cancer. And you can also see this on ultrasound, but it's more easily seen on MRCP. And a double duct sign in a biliary tree is almost always consistent with malignancy of the hepatobiliary tree. Commonly head of pancreas cancer. More rarely could be ampulla of Vater cancer, and even more rarely it's cholangiocarcinoma. As with the MRCP. Okay, so we did the diagnostic test. We did investigations such as the LFTs. Now we're doing some treatment. So he undergoes an ERCP. Shortly after the ERCP, he starts complaining of severe epigastric pain that radiates to his back. Okay, so what is the likely diagnosis? So, in this case, we already discussed this. It would be acute pancreatitis secondary to ERCP. So, in our attempt to try and help him, we caused him pancreatitis. Now, let's talk about the mechanism behind back pain. So this is another sort of, it's similar to the referred pain. However, it's nothing to do with sharing a common nerve innervation. It's more to do with the anatomy of the pancreas and its location. So the pancreas itself produces this inflammatory exudate. This exudate reaches the retroperitoneal space within the lesser sac. And this stimulates the sensory nerve endings within the back, causing this back pain. Now, I think this is a good visualization of this. So we have the liver here, we have the lesser sac, we have our organs here, our intestine. This is the transverse intestine, which with the greater momentum. And roughly here, this right there is the pancreas. So you can imagine if that's all inflamed, and it goes to the lesser sac, and this whole thing becomes inflamed, it's very close to the back. So that's why we can have this deep-seated back pain that radiates all the way to the back, because the pancreas is quite sort of posterior. And here's another diagram, which is AP. This is sort of a sagittal section, and it shows all the different organs. So here we have the pancreas, and if it inflames the lesser sac, all of this can become inflamed. So you can get this nasty epigastric pain from the front, and this nasty pain in the back. And that's because the pancreas is so deeply seated within the body. Same thing with the duodenum here, whereas all the other organs are more up front. And this is why it's important to know the lesser sac anatomy and the greater sac, and the lesser omentum, the greater omentum, because it helps distinguish and it helps you understand where the pain might happen. So in this patient's case, the pain is going towards the back of the pancreas. And we have to treat the pancreatitis. Okay, final case. So the final case is on gastroesophageal reflux disease. And with reflux disease, we have a patient, Mr. Feng, who is 60 years old, presents to his GP with belching, water rash, and heartburn. Now, I know I gave it away in the title by saying GORD, but this is typical of reflux. So burping, he has water rash, which is like water in the throat that he feels like vomit, like acid coming up, and he gets heartburn. Now, he's 60 years old, and he smokes 20 cigarettes a day. He's also a drinker. So the GP astutely suspects gastroesophageal reflux disease. Now, we have a nice scenario here, but let's bring it back to the anatomy and physiology. So what factors or features protect us against reflux? Well, with reflux, it's the stomach itself producing the acid, and we want to protect our own body from it because we need the acid to digest things, but at the same time, we don't want the acid to be destroying our own organs. Well, there's a few things. There's 4 main adaptations. So we have something called the lower esophageal sphincter. We have something called the angle of His, which is the angle at which the esophagus enters the diaphragm and the stomach. We also have the diaphragm itself, the crura, the 2 parts of the diaphragm surrounding the esophagus, helping maintain this sphincter, unofficial sphincter. And then we have also peristalsis. So the esophagus and the stomach have peristalsis, and that helps churn, so nothing gets stuck and nothing goes up the way. It always goes down the way. And I'm just going to give you a little picture here to help visualize this a little bit better. Now, when I was talking about the lower esophageal sphincter, we're referring to this area. And it's not a true sphincter, really. It's just a sort of narrowing of the lumen here. So this lumen just becomes a little bit thinner as it goes down. And we have the crura of the diaphragm. So diaphragm, as you remember, is just 2 pieces holding things together, and you have your ribs here, and you have your stomach there. So, and the esophagus goes just through here. Now, what helps with this is that this is a muscle, and it keeps the sphincter or within the esophagus in check, so it ensures that it doesn't become too big. Now, we can get problems with this, like hernias, which we'll get into a little bit later, but this is meant to prevent these hernias. We also get something called the angle of His, and the angle of His simply refers to this angle. This is quite a sharp angle, which means that the fluid rises up to here, and it doesn't want to go up the way. So it's a preferential system here where the fluid will rise up to the fundus, essentially, and not go up the way. And then we also have the peristalsis. So the stomach has a complex peristalsis system where it churns. So it sort of churns in a circular motion and also an up and down motion. However, this churning within the circular motion, because of the 3 layers of muscle, ensure that the acid doesn't go up. That with the peristalsis, if you have peristalsis of the esophagus and the gastric peristaltic waves, they try to be in unison to prevent any regurgitation. And with the incline of the angle of His, that once again helps prevent these things. Now, there's another anatomy question. So, where does the esophagus, the inferior vena cava, and the aorta enter the abdominal cavity? Now, this, for the longest time, I could not wrap my head around. I would just think, oh my god, I just have to memorize this. However, there is a trick for this. This is a visualization. So the inferior vena cava pierces at T8. Vena cava has 8 letters. 1, 2, 3, 4, 5, 6, 7, 8. So therefore, it's T8. So you just count the letters. Esophagus is at T10. Esophagus has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 letters. Therefore, it's at T10. And the esophagus is always more towards the right-hand side. Aorta. Well, aorta is T12. How are you going to remember that? Well, aortic hiatus. So A-O-R-T-I-C, that's 6, H-I-A-T-U-S. Aortic hiatus, because this is called aortic hiatus. So that's T12. That's the only way I can remember these. I've tried memorizing this, but this is the only way that's stuck. And this here is a view from below. So imagine we've cut someone in half and we're having a look from below. And we can see that the inferior vena cava is always more on the right-hand side. And the aorta is so close to the spine. So this is how we can differentiate the two in the abdomen. Aorta is always close to the spine, and the inferior vena cava is always at the edge. Now, and this thing here is a central tendon, so the diaphragm needs to attach to something, and it attaches through the central tendon. Okay, so this is a picture. One of the people in the years above me got a question like this, and at first it looks weird. What the hell am I looking at? But if we look at the previous picture for reference, this is an inferior view. That's our spine, those are our ribs, and this is the diaphragm. So A is the central tendon. So that's what attaches the diaphragm to the rib cage. B, as we know, since it's quite farther up, it's going to be the inferior vena cava because it's towards the right-hand side. C is an esophagus. Now, if you weren't sure if that's the esophagus, can you see these rugged little edges? It's sort of drawn like it's a squiggly line like that. The rugged little edges indicate that that's the muscles within the esophagus. So that there is the esophagus. D, the aorta, because it's quite close to the spine. And E is the psoas muscle. So this is the muscle we talked about earlier, and you would sort of expect the kidneys to sit here. So just to go over that again and to compare that to this reference picture, that's the inferior vena cava, that's the esophagus, that's the aorta there. It attaches via the central tendon, that's our vertebra there, that's our psoas muscle, so that's this muscle here. And the psoas muscle is important because it protects basically the organs from the spine. And it's a muscle that's also used in hip flexion, so it's important for that as well. But it's a protective muscle. And if you have an infection of the kidney or anything within here, it can get into the psoas muscle and cause an abscess. But that's for a different video. So now we continue. So Mr. Feng is referred to upper GI endoscopy. He has the barium swallow, and the barium swallow with the upper GI endoscopy reveals a sliding hiatus hernia. So what is a hiatus hernia? So hiatus hernia is the upper part of the stomach protruding through the diaphragm. Now why is it called a hiatus? So hiatus just means an opening. So it's a hernia through the esophageal hiatus. And there's different types. We have a sliding and a rolling. And the sliding one, the gastroesophageal junction slides above. So you can see the esophageal junction goes up. It slides into the chest. Whereas rolling, or also known as a paraesophageal, which I think is an easier way to remember this, is where the fundus of the stomach protrudes up. And it's the esophagus there and base of stomach. So it's a paraesophageal or a rolling hernia. And they're treated in different ways, but the sliding one is the more common one, like 80-20%. Okay. And the reason why the hernia happens is because it's the failure of those four mechanisms we discussed earlier. It's either a weakness within the diaphragm, it's a weakness of the patency of the lower esophageal sphincter, the angle of his here gets off, right? It's not a good angle anymore, or the peristalsis is out of sync. Okay, so moving on to the next thing, we have a cross-section of a gastric pit within the stomach, and we're asked to label it. So this is the stomach here, and what we see here in A is the gastric pit itself. These are the small little pits. And if we go further down in E, we have something called the gastric gland. So we have a pit, underneath is the gastric gland. And we have a whole collection of cells that do a myriad of functions. So we start from the top. So at B, we have something called a mucous neck cell, also known as a goblet cell. And what they do, they produce this mucus that protects the stomach lining. Because if you can imagine, you have hydrochloric acid in there. That can dissolve metal, that can dissolve a razor, that can dissolve anything. And we need to be protected from that. So what protects us? It's this layer of mucus. Now, when we take non-steroidal anti-inflammatory drugs, such as ibuprofen, it inhibits, through the COX pathway, these cells that produce mucus. So therefore, there's less mucus, and the acid itself becomes more irritable. So this is why patients might get an irritable stomach with ibuprofen. And there's some people who are more prone to this than others based on their cytochrome and other enzymes. However, it happens for most people, but some people are more sensitive to it. And that's because there's less mucus within the stomach. Then we move on to C. So C is the parietal cells. And these are the cells that produce the gastric acid. And they also produce intrinsic factor. Now, the gastric acid, that's self-explanatory what that does. It helps digest food. But intrinsic factor is very important as well. It's important in vitamin B12 absorption. And what happens is that it binds to the vitamin B12. And then later in the terminal ileum, it helps absorb this B12. And if you do not get this, you get something called pernicious anemia, where the vitamin B12 cannot get absorbed because of lack of intrinsic factor. And this can cause anemia and other malabsorptive conditions. Underneath that, we have D, which is chief cells. Chief cells produce pepsinogen. Pepsinogen gets activated in the acidic environment to make pepsin, which digests protein. At the very bottom here, which is not labeled in this diagram, we get something called D cells, which secrete somatostatin to inhibit acid secretion. And then we have G cells, which create gastrin to stimulate acid secretion. So at the very bottom, we have the homeostatic cells, which keep the pH level within the stomach. So somatostatin inhibits acid secretion, that's the D cells, and G cells, gastrin, they stimulate acid secretion. That's just answers there. Next question. So this is a typical second year question. They ask, describe the mechanism of acid secretion in the stomach and how this is mediated. And I like diagrams. I learn with diagrams. And I think this is very self-explanatory on its own. If this is sort of immortalized in your brain, then you will never have issues answering this question. So we have the mucosa, so that's the stomach lining. That's the inside of the stomach, and that's the blood, plasma. So there's something unique about the parietal cells, and that is that they contain carbonic anhydrase. Now, carbonic anhydrase is an enzyme which catalyzes this reaction here, and it enables the conversion of CO2 and water into H2CO3, which then leads to HCO3 plus H2O3 minus, and hydrogen ions. So this helps generate hydrogen ions within the cell. That's the first step. Carbonic anhydrase within the parietal cell generates H plus ions. Now there's two fates with these two molecules. So we have our bicarbonate going one way and our H plus, our proton, going the other way. Now for the hydrogen ion, we have something called a proton pump. The proton pump works by producing H plus out and potassium in. And this is very important because if we, for example, need to inhibit this, because we're too acidic, we give a proton pump inhibitor, like omeprazole, and it acts on this section. Likewise, if we vomit, we lose acid, and we try to gain acid, so we try to exchange potassium. So we might get more potassium as a result. Now, HCO3 comes out because it's part of the bicarbonate tide, because the HCO3 concentration within the cell is greater than that of the plasma that comes out. And then we have chloride because we need to balance the charges within the cell. So HCO3 so the bicarbonate is exchanged for chloride ions at the base of the membrane. This is because our plasma contains chloride. And then the chloride, because there's more chloride inside the cell than in the gastric lumen, the chloride just diffuses in. And that creates hydrochloric acid, H plus and Cl minus hydrochloric acid. So we get a bicarbonate tide and a chloride shift. And this is so that we get good acid-base balance. And then the hydrochloric acid is secreted via the intracellular canaliculi of the parietal cell. And basically that's just this part, that's the intracellular canaliculus. So how do we regulate this? So I described to you how it's produced, but how is it regulated? Well, we mentioned this before. So we get something called gastrin. So that's a gastrin molecule, and histamine. And they increase acid secretion. If we want to decrease acid secretion, we inhibit histamine with a H2 receptor antagonist. That works at the tail end of the parietal cell rather than the gastroglumen end of the protein pump inhibitor. Likewise, somatostatin decreases the acid secretion. That's through the M1 receptor. Okay. So he has an upper GI endoscopy because everyone with reflux disease gets upper GI endoscopy. And you find that the changes are in line with Barrett's esophagus. So what does this mean? So these changes that they're referring to is something called metaplasia. This is when the epithelium turns from sort of stratified squamous non-keratinized epithelium into columnar. Now, what's important about this is that columnar epithelium is present in the stomach. And the reason it's present in the stomach is because it needs to be that way to deal with the acid within the stomach. Now, if the acid splashes back up, like in reflux, and damages the esophagus, well, then it tries to remodel, because squamous is meant for smooth passage. But if you have extra noxious environment, it will turn into columnar to adapt. So the epithelium within the tail end of the esophagus, the lower part of the esophagus, will start resembling stomach epithelium, columnar epithelium. What is the significance of this? Well, a Barrett's esophagus has an increased risk of esophageal cancer, specifically adenocarcinoma. And this is a risk factor, and it alerts the gastroenterologist and the whole team to say, okay, this patient needs to be notified that they're at risk of esophageal cancer. Now we need to treat this. We need to treat GORD. How do we do this? So next question is, name 3 drugs that can be used to treat GORD. Well, we have acid-lowering therapies, and then we have gastroprotective therapies. So our acid-lowering therapies are our protein pump inhibitors, which is our omeprazole and lansoprazole. They inhibit the protein pump at the canaliculi of the parietal cell. And we have histamine 2 receptor antagonists, which is cimetidine and ranitidine. These are not used as much because the proton pump inhibitors have much better outcomes. However, they stimulate the tail end of the cell, the plasma side. You can also get something called aluminum hydroxide, where with these two, we don't modify the parietal cell, but we try to target the contents of the stomach itself. So the aluminum hydroxide, when you take that, it binds to the free protons, the H+ ions, and it reduces the acidic load. Whereas the alginates, that's your Gaviscon, that creates a protective layer around the stomach. So this protective layer around the stomach essentially prevents the damaging effects of the acid. All right then. Thank you everyone for watching. That's the rest of the slides. I hope this was helpful. I plan on making more of these. And so for the next couple of days, this was more GI focused. And I'm thinking the next one will be more neuro focused. So let me know if that's something that will be helpful for you guys. This should be made available right after this gets uploaded. I'll make sure you guys can rewatch it. And good luck with your revision. I hope this has been helpful. And if there's any questions, ask in the chat. There's the email address that I put on the Facebook post. So please feel free to ask. And good luck with your exams.